Welcome to part B of chapter 10, where we wrap up somatic senses. So this will be the final video for week 5, and then we'll pick up with special senses starting in week 6. I was thinking about labeled line coding last night, and I decided that I would go ahead and include this slide to help you understand the nature of labeled line coding a little bit better. Let's say for a moment we're looking at a patient that's facing away from us. So this is in fact the right side of the brain. If you have a sensory signal, and particularly a mechanical stimulus, a touch stimulus of some kind, that originates on the left side of the body, it'll cross the midline, and we'll talk about that in a little bit. It'll cross the midline, route to the thalamus, and then the thalamus will project that signal to an area of the somatosensory cortex which is assigned for that area. And we have more neurons assigned in the somatosensory cortex for areas with smaller receptor fields, like your fingers or your lips. See how large the lips are on this representation? And how small things like the elbow are relative. That's because the receptor fields are larger, fewer neurons. This is a classic example of labeled line coding in the somatosensory cortex. Last time we were talking about location and the idea of population coding. Multiple receptors functioning together. Which receptors fire and when can give rise to location, but can also give rise to things like intensity or qualitative aspects of the stimulus. Like which receptors are firing when gives us a sense of pitch and of loudness and certainly of location. Beyond that, we have what's called lateral inhibition. And lateral inhibition also works with location, just in different areas of the body. If, like for instance, hearing, the population coding gives rise to these phenomena, lateral inhibition is very, very important for very fine touch, for very small receptive fields, and for vision in particular. So again, temporal population coding can give rise to location in the auditory side of the equation. Let's move into lateral inhibition now. Now, lateral inhibition is fundamentally a type of neuroarchitecture-driven mechanism, but it allows for very, very precise location and discrimination, like I said, particularly with vision and very, very fine touch. It's hard to get a more localized phenomenon than a sharp pinprick into the skin. Nevertheless, when that happens, you may get ancillary stimulation of additional fields, especially in high receptor density areas. So in your retina, it's exceptionally high, but in areas of your skin where there are very lots and lots of small receptor fields, you can get accidental activation of nearby receptors. Well, you can look at B here, which is the center of activation, and A over here is getting activated, and C over here, but these other guys are not. In any case, we show at the secondary neuron level. So this is the primary sensory neuron, secondary, tertiary. That's where we get the phrase higher order. So the more neurons we go, the higher the number gets. That's what higher order means. In any case, B is strongly activated and A and C are weakly activated. So we have lots of neurotransmitter, lots of action potentials here, maybe a few action potentials. We're getting a little bit of signal here. If this signal went all the way to the central nervous system, it might appear as a much larger stimulus than it actually is. But at the secondary neuron, what we see, and these guys don't have them, but they would also have these. And I will show you the architecture of the retina later on to illustrate that lateral inhibition. But in any case, that secondary neuron, its axon actually is divergent. It actually has multiple presynaptic neurons. And so while it may be signaling its tertiary neuron, it's also sending inhibitory signals to those secondary neurons adjacent to it. And if we look at this in a graphical form, what we get is that the primary neuron is proportional to strength there, so we're getting a strong signal, but it will send inhibitory signals to its neighbors, leading to diminution of signal, either no signal at all or very, very weak signal. And so we get a primary focus down that B pathway. And here's the graph. So maybe strong, yeah, maybe a little bit, in terms of the number of action potentials. After we have that secondary neuron filter, if you will, what we see is B is enhanced, but A and C are actually reduced. And that causes a greater localization of signal at B. And that's how lateral inhibition generally works. The idea is that these secondary neurons are sending inhibitory signals to prevent neurotransmitter. So this is one of those examples of summation occurring at the presynaptic terminal, preventing calcium and exocytosis from doing their thing. Let's move on to the discrimination properties of intensity and duration. Intensity can be fairly straightforward. We've already talked a little bit about intensity with auditory stimulus. The number of receptors activated, well, that's population coding. How many receptors are active and when? So it can give us intensity. It may also give us quality, like in the case of what kinds of sounds we're hearing and so forth, but it's still population coding. The other side of intensity gets back to something that we talked about in Chapter 8, the frequency of action potentials. That if you have more action potentials in a given period of time, that will lead to more neurotransmitter release, which will mean to a stronger graded potential downstream. Relative refractory period. If we have more frequent action potentials, that means stronger intensity of signal. So a combination of how many receptors are activated as well as how often they are firing their action potentials gives us coding for intensity. Then we have duration, and I would say that this is coded primarily by the change in frequency that we see. So we see the duration of a given action potential frequency. And what we have is that some receptors can and do adapt or even cease to respond to a stimulus altogether. So down here at the bottom is the stimulus. So here we have an on, off. We call that a square wave stimulus, and I'm going to show you more of this in a little bit. Here is the receptor potential, and you can see over here on the left, it fires off briefly. Then it may fire off again when it shuts off, but in between it's not firing at all, even though these stimuli are identical. Look at this one. Fires off, and then it just creeps down a little bit. It's adapting a little bit, and then off. Look at the action potential frequency. A few here, a few here. This one fires off quickly at first, but as the graded potential weakens, you get further and further apart. Back to that idea of relative refractory period. This phenomenon here we call tonic and phasic in terms of receptors. Phasic are rapidly adapting, tonic are slowly adapting, but never diminish entirely, never go away entirely, not normally anyway. So let's look at this from pictures in your book that I've sort of brought together. So we have a modest signal here. By the time it hits the trigger zone, we get a good pattern of action potentials. It should start to kind of get wider as that falls off, and we get a response. Get a stronger situation, okay, stronger square wave. You can begin to see that adaptation. Most all receptors do adapt to some degree. And you can see that in the trigger zone, in the what we would call the axon hillock or the initial segment. Strong action potentials early on that do begin to fade, in terms of frequency just at the very end, but it never fully adapts, and we have a fair amount of neurotransmitter release in that. But again, the stimulus doesn't vary, but the response does. The stimulus doesn't vary, but you can just kind of see the edge of it. It's kind of sloping a little bit there. The response does, and most all receptors do adapt to some degree. This is what we would call a tonic receptor, for instance, vision. If we go out into the outside, if you've been in a dark room for a little while watching my lovely videos, and you walk outside and it's bright outside, well, if at first you're going to be somewhat blinded, but your eyes adapt, but you don't stop seeing, right? Your eyes adapt to the bright light. It's just that there's an adaptation and eventually it settles down into a lower level of response. There may be a spike at first, a relatively intense period, followed by an adaptation, but you never completely adapt to the stimulus. Vision is very, very good. Taste would be in that sort of same area. But on the opposite end, smell is very, very much a phasic situation. So phasic, again, we have that square wave, and the way the book presents it is that you have an identical receptor potential. That may be true, that may not be true. In any case, let's assume that this is our norm. We have that, have that receptor potential, but look at the action potentials here. You see, we have action potentials during that intense phase, but when we get into that plateau and adapt, and then finally we tail off at the end when the stimulus goes away, there's no action potentials whatsoever. This is what we call phasic. Sense of smell is very, very phasic. Certain types of touch receptors on your body are phasic. The temperature receptors on your skin are phasic. They can sense change in temperature, but they really don't do a very good job of sensing absolute temperature. The receptors in your hypothalamus are much better at absolute temperature than relative. But what explains this? We have the same graded potential, but why don't we have action potentials? Isn't that strange? Why aren't we firing off action potentials if we're above threshold? The simple answer is the threshold has changed. Something about the makeup of the channels here has changed so they are less receptive to a given voltage. Requires a higher depolarization event in order to trigger a threshold. That's what's going on here. Is there's a change in the threshold of these receptors. See right there? Okay. That's what a phasic receptor is generally doing. Again, we're generalizing a lot here. There's, but at least for our purposes, I think that works well. So we've completed the discrimination part of this talk, and now let's put these receptors in the context of the neural architecture. We've talked about this a little bit, but let's start putting some pieces of the puzzle together. If you have a potentially injurious or a potentially noxious stimulus, what happens is as it comes in those afferent neurons through the dorsal horn of the spinal cord, the dorsal root horn, it will integrate immediately at the level of the spinal neuron. That is to say, it will synapse, it will cross the midline, and effectors will be integrated into this response. It's certainly going to be perceived if it's of enough intensity, and so it'll route up through the thalamus to the somatosensory cortex charged with that region of the body, and you'll perceive it in that region of the body. But this spinal cord integration is critical, and I'll explain that in a little bit. On the other hand, let's try a different scenario. Let's say in the same area of the body, the same region, we get a non-noxious stimuli like a fine touch or proprioception. What will happen is it'll still route through the dorsal horn, that's the afferent pathway, but instead of integrating at the level of the spinal nerve, it'll actually integrate up in the medulla, across the midline, and so forth. Both pathways do route through the thalamus if they're on their way to perception in the conscious center. So the thalamus is going to be responsible for both of these signals. But what will happen is we'll integrate it here some more, send it to the conscious center, and decide what the response is. But I want to bring us back to step one right here. This idea that we're going to cross the midline with these noxious stimuli. With nociceptor pathways and potentially injurious stimuli, we have the need for speed. So if we have a situation where nociceptors are activated, or we have particularly intense signals coming through our receptive fields, we want to have some kind of a protective response that preempts the processing, if you will. And that's one of the reasons why we integrated the spinal cord is fewer synapses. Synapses are limited by the kinetics of diffusion and exocytosis. As fast as they might be, if you're having to route through several thousand neurons, it's going to take time. And we need that withdrawal reflex right away to limit injury, to withdraw from the injurious stimulus. So here's our figure again. So our fine touch, again, not likely to be injurious, routes up through the medulla. Injurious stimuli route across the midline at the spinal cord. So things like pain, temperature, coarse touch are all routed, again, through that sort of labeled line coding, if you will, that neural architecture at the midline of the spinal cord. And that's because these are all examples of potentially injurious stimuli. So we've routed them at the spinal cord, and that will allow for rapid integration for responses, either what we call ipsilateral response or contralateral response on the other side of the body. For instance, let's say you touch a hot pan. Well, the ipsilateral response would be the withdrawal reflex of your arm, but you may actually push away with your foot on the opposite side of your body to get away from, or rotate your shoulder away from the side of the stimulus. That would be an example of a contralateral response. If it is significant enough, it will certainly register as conscious sensation, but oftentimes your response occurs ahead of that conscious sensation, even if it's a fraction of a second. Now, this picture is from your book, and they talk about lots of different types of receptors and so forth. I'm going to let you off the hook on this. I'm not worried about these different types of receptors. If we have a lab or something, maybe we'll talk about them a little bit. You know, it's just a sort of a form of anatomy, if you will. The one I want to key in on, though, since we're moving in that direction, are the free nerve endings, which are the ones responsible in some cases for that perception of temperature and coarse vibration and reception. So free nerve endings. The way I would kind of put free nerve endings would be to say that they have a slightly higher threshold, but they are generic in the types of stimuli that they will respond to. Almost any stimulus of a given intensity is going to trigger off these free nerve endings. And given that nociceptors are primarily free nerve endings, nevertheless, there are subdivisions in those free nerve endings. For instance, the thermoreceptors, we have cold receptors and warm receptors. Just got a little picture of it here. The main thing about these receptors is that they are sensitive to change more than they are absolute temperature, and they are generally quite phasic. Have you ever tried to get into a swimming pool and you just have to creep in because you just don't, because it feels like needles on your skin, it feels really, really cold? That's due to the fact that these thermoreceptors are sensing a temperature change. Air is a relative insulator, and if your skin is warm and dry, your skin will have a high temperature, but then you get in the water and immediately heat is conducted off that skin and those cold receptors kick in quite intensely. But then after you kind of, go for it and jump in and get yourself immersed, those cold receptors actually adapt. And we're going to try an experiment to help you observe that in real time. And no, I'm not going to have you jump into a swimming pool, but I have an experiment for you that I hope you guys will participate in to kind of see this relativism of these receptors. Warm receptors typically will feel above body temperature, somewhere to quite a warm temperature, and above a really warm temperature. This is about 120 degrees or so. You start to kick in the regular nociceptors. So the nociceptors are sensitive to temperature, but only above a certain point, probably because of other cells kicking in. So when nociceptors fire off, it's almost certainly a noxious stimuli of some kind that's actually causing cytokines to be released, like histamine or substance P. We have a whole population of cells that live out in our tissues, like mast cells and other types of and regular old cells that when they are irritated will begin causing the inflammatory response. And so they'll release things like substance P and histamine and so forth. So we have this injury here. We have cytokines released immediately by things like mast cells and so forth that then fire off those nociceptors. Free nerve endings, just some slight subdivisions, if you will. So the signals that mediate pain and itch, which tend to run through similar fiber pathways, it's just a matter of what the cytokines that are involved. For instance, itch is often associated with mast cells and histamine. Pain can involve different receptors, and it's a little more complicated than I'm prepared to discuss. Nevertheless, here's the sort of generality for you. If we have itch going on, one of the primary cytokines is histamine. If it's just histamine, maybe some serotonin in there, we're gonna perceive that as itch, triggering certain types of nociceptors, chemosensitive nociceptors, that then register as an itch. If it's an outright pain, yes, there's going to be subjective perception there, and I'm going to talk about that in a little bit. But what happens is if we have sharp localized pain, what's happening is the primary neurons are interfacing with a type of sensory fiber called an A delta fiber. That little funky looking symbol is the Greek letter delta. A deltas are myelinated fibers. So it's a fast pain. That's why we call it fast pain. It's very sharp. It's very localized. On the other hand, other types of pain sensors will move through unmyelinated fibers that are much more branched. These guys tend to be sort of a single pathway. But C fibers, on the other hand, unmyelinated C fibers are branched and they are slower, and the pain can be intense. It's just that it doesn't feel like it's localized to any one area. It's more of a regional feel. It's more diffuse around a whole area. If you've ever bumped your elbow, like your funny bone or something, you'll get that immediate ow right there, and then the rest of it really kicks in. If you know what I mean, that slower C fiber pain can really ramp up, but it usually takes a couple of seconds. That's because these guys are unmyelinated, and the reason it feels duller and more diffuse is because it has multiple branches, and you can't propriocept it, in the same way. Have more to say about that when it comes to referred pain down the line. But here's our A delta fiber. It's relatively small in the scheme of things. It is myelinated. We often feel it with cold as opposed to heat. Yes, heat and cold can come up to C fibers, but cold seems to have a preference up these A delta fibers, which is one of the reasons why we might perceive cold faster. If you have multiple stimuli, you might feel the cold first. Fast, localized pain. Mechanical stimuli in some cases, a bump or a trauma type injury. C unmyelinated fibers are the smallest. You can see they're much smaller, so their kinetics are going to be slower. They're unmyelinated, so slow pain, that's the big one here. Yes, they can feel heat, some cold, some mechanical stimuli, but the big difference is in this fast pain, very localized, slow pain, less localized. Well, what about this A beta thing up here? Why is this in this chart if we're talking about pain? A beta fibers, very, very large, they're myelinated, they don't perceive pain, but they have a role to play in pain modulation, and we're going to talk about that. I just want to touch on this for just a second, that pain is a complex phenomenon, and it is subjective, and it can be modulated by all sorts of interconnecting neural pathways. Certainly experiences and memory, the plasticity of the brain, and so forth. There are a lot of theories about pain. What I'm going to do is show you one of the leading theories of pain, and it's a neural architecture type modulation of pain that involves that A beta fiber. We call it the gate control theory, and it is one of the most important theories of this semester. It is a multi-billion-dollar, probably $1 trillion idea, the gate control theory. We're going to go through that mechanism. So in talking about the gate control theory, we need to sort of set the stage for what fibers are involved and where all this is happening. Remember that we're integrating at the level of the spinal nerve. Now, there's a lot we're not showing here. This integration step isn't just simply routing up to the conscious center. It's also integrating with other neurons mediating ipsilateral and contralateral responses. This is a noxious stimulus here. We're primarily involved with C unmyelinated fibers. It doesn't mean that A deltas aren't involved, but for complexity purposes, we're going to focus, and there's more evidence that C unmyelinated fibers are modulated this way. In any case, we have this fiber coming in and it's synapsing with its secondary and tertiary neurons on its way up to higher order neurons. Under basal circumstances, unstimulated circumstances, there is another neuron here that creates this sort of closed loop. We call this the inhibitory interneuron, and it's got fancier names out in the literature for sure. And there are different kinds of inhibitory interneurons. Again, for complexity's sake, we're just going to call it the inhibitory interneuron. And the dark shaded color means that it is more active. So we have a dark blue here. Notice that the C fiber is clear and the secondary neuron or the tertiary neuron is clear, but that blue fiber is active. It is constitutively active in this situation. It's an inhibitory interneuron. What's happening is it's actually hyperpolarizing this cell body here. That's a cell body there with the dendrites. It's hyperpolarizing it with a neurotransmitter. It's using an inhibitory. This is an inhibitory postsynaptic potential, and we're hyperpolarizing this, preventing from action potentials from going up here. Because remember, any action potentials here are going to be perceived as pain. So we're dialing down, preventing any accidental signals. So nothing going on there right now. Now let's add to the stage a stimulus of some kind, noxious stimulus. And so we're going to get action potentials coming up this fiber here, which is going to do two things. First of all, it will de-inhibit this synapse. When we were not signaling, this neuron was dark blue and was hyperpolarizing this neuron. So now we have we're hyperpolarizing the inhibitor, preventing it from sending action potentials. And so we are de-inhibiting. That's what we mean by inhibition stops. This is an inhibitor, and we are de-inhibiting. So now that gate is now open. This is the gate in the gate control. So this gate is open, plus we're exciting, so that means we're going to send a nice strong set of action potentials to the brain, and we perceive pain. Now let's add to the stage this A beta fiber, which is not a pain fiber. It's a large myelinated fiber that's usually conveying deep touch, non-painful type stimuli. What the A beta fiber will do when it's activated alongside the C is that it will begin re-energizing, shall we say, or re-exciting that inhibitory interneuron. It's not dark blue like it was in the very first slide. It's a light blue, so it's sending a few action potentials down. But that additional stimulus is now causing inhibition on this. The gate is beginning to close again. It's not fully closed because we still have, some signal from the other C myelinated fiber, but it's not as intense as it was because we're sending fewer action potentials down this. We are repolarizing or, getting this down so it's not firing as many action potentials, and so the perception is going to be less intense. That's why, like for instance, if you, if you've been involved in sports, you've banged your toe or your knee or something, and the coach goes, "Walk it off" or "Rub it out." You know, when you instinctively begin rubbing someplace that's sore, you are engaging the gate control theory. By activating that A beta, by massaging that area, or using a tense unit, or using acupuncture, you are closing that gate a little bit and reducing the pain. That is the gate control theory. And it's a very, very powerful theory. And a whole lot of pain therapy centers around this idea of this neural architecture regulating this gate on how much pain we perceive. A couple other aspects of pain. And we're going to use these as sort of examples of the larger issue that when it comes to pain. For instance, this statement here, ischemic pain is due to lack of adequate blood flow. And the larger issue is that pain is meant to be a warning. That pain is meant to be a warning. It is saying something is wrong, or avoid this because you're going to cause injury, or refrain or otherwise do something about the inadequacy in the tissue. And so ischemic pain is exactly that. You don't have enough blood flow, not enough oxygen, and the tissue starts sending out cytokines, which activate nociceptors and try to cause inflammation and vasodilation. But our patient in the sickle cell preview that I showed you, the reason sickle cell patients feel so much pain is that the blood flow on the microscopic level virtually everywhere in their body is occluded by those sickling cells. And so they're feeling large-scale ischemic pain. On the other hand, chronic pain is often a pain that is present that is absent of any noticeable pathology. It's persistent, usually persistent at least for months, but there's no obvious injury. Now there are some issues with chronic pain where you have a chronic injury where you're feeling pain, but true chronic pain is pain absent of an actual stimulus. And it leads to anxiety and depression, certainly discomfort. And the problem is that we sort of have this issue with opioid prescriptions. When the over-the-counter meds aren't working, these patients want to be treated, but we are confronted by addiction issues and abuse issues. So chronic pain is a real problem because it's hard to treat in the first place. It's persistent. We don't always know what the cause is, and in the face of abuse potential, makes it even more difficult to treat. That said, I want to talk about a couple of analgesic drugs. The first being aspirin, or that's going to be our representative, or I would say written larger are what we call NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. And then we're also going to talk about opioids. And here is the basic mechanism of action, but I'm going to illustrate it further for you in the next slide. Let's start with NSAIDs, which stands for non-steroidal anti-inflammatory drugs, like for instance aspirin or ibuprofen and so forth. What's happening is that when we have cell damage or injury of some kind, inflammation, there are enzymes in the cells which will cleave phospholipids literally within the membrane and create a molecule called arachidonic acid. When arachidonic acid is made, there's another enzyme called cyclooxygenase. It's the cyclooxygenase isoform number 2. There are actually 3 different COX enzymes, and this is COX-2. You might hear that phrase. Cyclooxygenase converts arachidonic acid into molecules known as prostaglandins. That's what PG stands for. Prostaglandins. So this is happening in our tissues like muscle and fibroblasts and so forth, and that leads to pain. It's because this prostaglandin is a very good nociceptor agonist. Once it's released, it will lead to perception of pain in particularly see on myelinated fibers, but any fiber A deltas as well. A non-steroidal anti-inflammatory drug like aspirin, or in this case I have ibuprofen here, inhibits cyclooxygenase enzymes. Often we have specific types of drugs, Celebrex and some others, that are much more specific for the 2-isoform. In the past, we've used less specific ones. Aspirin will inhibit more than one isoform. But in any case, this isoform is inhibited. That leads to reduced production of prostaglandins, which leads to reduced pain. It's very, very effective, especially with C-unmyelinated fibers. But the one thing to keep in mind is that this is occurring at or near the site of injury. This is occurring in the peripheral tissues. It's occurring in the peripheral tissues where the injury has, or the insult of some kind has occurred. For opioids, what I would like to do is refer you back to the gate control theory. This synapse right here, this synapse right here, and this synapse right here all have inhibitory interneurons that have opioid receptors. And these receptors are actually sensitive to endogenous opioid peptides. When I was training for a marathon, I actually experienced this firsthand. They talk about a runner's high, and it's very, very much the truth. One day I woke up, I started running. I was planning on running a certain distance, and I was feeling so great. I ended up running 21 miles. That's that endogenous opioid peptides that these drugs are mimicking. But again, it's at the synapse here, and the synapse up in the brain. If we have pain and we inhibit those synapses by activating this inhibitory interneuron, okay, by turning this guy on with those opioid peptides, we then cause cessation of pain perception. There may still be injury here in some cases. In the case of neuropathic pain, you may be, let's say the neuropathy pain is down here. By blocking these synapses, you now can block that neuropathic pain. But the key here is that it is acting just like the gate control theory. That's your key. We're turning on this inhibitory interneuron, hyperpolarizing these synapses so that you don't have neurotransmitter secretion, and thus you're blocking pain. This occurs in the neural synapses, and it's very, very similar in many ways to the gate control theory. In fact, it corroborates the gate control theory. There are issues with side effects up here. You're going to see, you're up in the higher order neurons. That's where you have your addiction issues and other things. So that's the mechanism of opioids, and we have the mechanism of NSAIDs. Just a good start, because these are so common in therapy for any number of reasons. Pain is one of the most common reported effects that patients have. So getting to know these two mechanisms gets you a good start. The last aspect of pain in this, and I just have two more slides, is what we call referred pain. Referred pain. And this, again, is a neural architecture situation. Referred pain is by far most common with branched pain fibers, particularly C-unmyelinated fibers. For instance, if you are having a heart attack, you don't feel sharp, what we call precordial pain. You do not feel sharp sternal pain. It is not localized. It is diffuse. And it spreads across the shoulders. It feels like someone is sitting on your chest. Sometimes it radiates down the arm, and more often in females, it'll radiate down the back a little bit. And that has to do with the branching of the neurons that service the heart. It not only services the heart, it services all of these other areas. And so that's where we perceive it in the body. Liver and gallbladder we perceive in the shoulder, or perhaps just underneath our rib cage. Again, that's a form of referred pain. Belly pain is really, really tricky because it could be any number of about 20 different things. you can see that the areas are very general and not particularly localized. Your readers are kind of fun. So folks that have kidney stones, they get a sort of a belt-like phenomenon across their hips. It is believed to be the result of a convergent pathway of these neural fibers. You have lots of individual fibers converging into secondary and tertiary pain fibers going to the central nervous system. Page 275 for you. Here's an image of that neural architecture showing that we have primary sensory neurons. These are the primary nociceptors. There are both synapsing with a common secondary sensory neuron. This is convergence. We can have convergence in an individual neuron, like this one has multiple fibers serving that one organ or multiple fibers on the skin, but yet we still have additional convergence at the secondary sensory neuron. And so your body perceives it not only in the organ of injury, but also in the skin or other surfaces or areas that are serviced by this common pathway. So that wraps up the first part of Chapter 10, a truly massive chapter in this semester. We will come back to Chapter 10 for the special senses next week. But again, there's a lot going on here. Take your time with this material, take good notes, and understand the different aspects of sensory perception, sensory modulation in some cases, transmission, and so forth. Let me know if you have any questions. Thanks for your time, and I will talk to you again soon.